What's going on, little? Good morning, August 28, 2025. I'm Dr. Duke Majan, CEO and founder of Duke Spine Institute. Our patient travels here from Indiana. He is having the lower back and neck special. Earlier this week, we performed surgery on his lower back for some disc issues. He has 100% of that pain is gone completely. He's so happy. Now we're going to work on 3 discs in his neck. He's got 3 herniations. He's been incapacitated with back pain for the last several years. Same thing with his neck. Today he's getting his cervical disc repair done for 3 herniated discs in his neck. If you have questions, feel free to ask them. Let's start with playing our video on what causes neck pain, chronic neck pain. I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3, next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Duke plasma rhizotomy is the best treatment in the world available for painful facet joints. Duke laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. Welcome back. Before we talk about the 30 causes of neck pain, take a look at the tear in the back of this disc. Look at that. That black line right there, right to left. Show us the inner part of the tear, the innermost part of the tear. Nope, that's the nucleus. Go left, stop. Right there is where the tear starts. And then go to the left. That's all tear that he's pointing to, and there's the herniation. You can actually see the herniation right there, yep. So we are at C6-7, the bottom disc that we're going to fix for this patient. We just did a discogram. It's a chromodiscogram, which shows us basically the tear. The entire surgery we're performing is done with a 4 millimeter incision, tiny, tiny 1/4 inch incision. Sorry, not even 1/4 inch, about 1/6 of an inch. There's no metal, there's no fusion, there's no hospital, there's no downtime. This patient's going to go back to a normal life the next day. We've never had a complication, surgical complication, and by the way, there's virtually no bleeding and no post-operative pain. So we got a little, I can't really see because the shadow. Can you help with the light? Yeah, that's better. 4 millimeter incision. Shot. Let me go ahead and get this done, and then I'll talk to you guys about the 30 causes of neck pain. So I've got the needle placed perfectly. Then we've got the guide wire that went through the needle. Now we're going to place a dilator over the guide wire. This technique that I'm showing you right here was developed by the Koreans, South Koreans, Dr. Seng-Ho Lee, Dr. Gun Choi, over at Woodydal Hospital shot. And they were the first ones to do this anterior cervical transdiscal endoscopic surgery. And they taught me how to do this as well. You can see the dilator is now sitting right in front of the spine. Show us that, Jordan. And then let's go to an AP view. There's the dilator tip, there's the front of the disc. Now, people ask me, don't you damage the disc when you go in? The answer is no, because we're not cutting the disc. We are spreading the fibers of the disc, spreading the annular fibers. Shot. Perfect. We're just in the midline, just to the left of the midline by about 3 millimeters. That's perfect. Very happy with that. So the 30 causes of chronic neck pain. Why do we use the qualifier chronic? The answer is, if you do something to your neck and it hurts today for the first time ever, that's called acute pain. But chronic pain means you're living with it every day of your life. And chronic pain is what most people want to get rid of. Like acute pain, we all can deal with for a day or two. If we have a muscle spasm or something, no big deal. If you have viral meningitis, no big deal. But it's when you have to live with neck pain every day of your life that it becomes a problem. It interferes with your daily activities. And that's when people really want to get their neck pain fixed. So they want to know, first of all, what's causing it. And Duke Spine Institute is the first in the world to describe the 30 different causes of neck pain, okay? We've lost about 5 drops of blood so far. And you can see the incision is tiny. It's about 5 millimeters today. You guys see that?
Yes, we do.
Huh? What? No. So the first step in curing neck pain is to know where it comes from. And there's really 2 main sources of chronic neck pain: the disc, the facet. The disc and the facet. Now the disc is what we're fixing today. And the facet is the second most common cause of chronic neck pain. But this patient has disc pain, and that's what we're going to fix. Now, besides neck pain, the disc herniations that we fix can also cause headaches, and they can cause arm symptoms. What are the arm symptoms? The arm symptoms are weakness, numbness, tingling, and pain down the arm, from the neck down the arm. Those are the arm symptoms. So this surgery we're doing today, the Duke Laser Disc Repair on 3 discs, is to fix neck pain, headaches coming from the neck and the disc specifically, and arm symptoms coming from the herniated disc. That includes weakness, numbness, tingling, and pain going down the arm. This patient and every patient is different in what symptoms they have, but the core symptoms that everybody has are basically the same: neck pain, cervicogenic headache, arm symptoms. It's just everybody has a different combination and little bit different sensation or different severity or different exacerbating. But in the end, There's one common denominator for that pain, and it's the disc. The disc is the source, and it's specifically a tear in the back wall of that disc. I discovered that 20 years ago when I was doing the Duke laser disc repair to treat arm symptoms, pain down the arm. I discovered that these herniated discs don't just cause arm symptoms, they also cause neck pain and headaches. Okay, and so we've been treating patients with discogenic headache and discogenic arm symptoms and discogenic neck pain, headaches, and arm symptoms for 20 years. If you have questions, feel free to ask them. In the meantime, we're heading down to the herniation. You can see it there at the bottom of the tube. I'm going to advance the laser fiber. There it is. Unlike the other scope we use, which is a bigger scope, this scope is smaller. It's 4 millimeters. There's a piece of herniation right there, our first one, the blue. And it's right at the back of the disc there. You see that? That's right at where the tear is. And it's not coming out easy. It's stuck down. So that's why we need the laser to release the stuck down herniations. I'm going to advance the fiber just a little bit. So, any questions? There's a piece of herniation right there. You guys see it wants to come out.
Yes, we do. And we have a good amount of questions. This first one's coming from Jason on YouTube.
Ah, Jason's back. Welcome, Jason.
Saying, oh my God, this guy had lumbar and cervical disc injured. Was this patient in a car crash or something?
Yes, he was. As a matter of fact, the patient was in a car crash. Yes, you're correct. What's that? He was rear-ended, apparently. I can't give you... Huh? High-speed rear-ending car accident. High-speed rear-ending car accident. I don't want to give you too much detail. I don't want to give away his identity, obviously, but he's from Indiana. And I think you said Fort Wayne, right? So, anyway, long story short, there's the herniation right there. We're using the laser to remove it. And once I remove this herniation, his disc will heal itself. It just cannot heal itself right now because of the herniation right there that you're looking at. You guys see that? There's a little bone spur right here. I'm getting rid of that. But I'm out in the right foramen at C6-7. You guys are watching the very future of spine surgery. It hasn't even caught on to mainstream neurosurgery. A lot of neurosurgeons don't know how to do this surgery. By the way, there is the edge of the spinal cord. You guys see it?
Yes, we do.
It's literally right around there. That's the edge of the spinal cord. We're in the foramen. Huh? We're going to start with the C6-7 disc, and then we're going to move our way up. Look at this thing. It's just like a big disc cheeseburger just sitting right here in the tear, holding the tear open and causing all the symptoms that this poor patient is having. He said his life was ruined. You guys are going to see his video testimonial for his lower back. Henry shot that yesterday. Was it yesterday?
Yep.
Yeah.
Yep. Yesterday.
He's so happy his back pain is completely gone. And here he is getting his neck fixed as well. He got a twofer. Unable to work for 3 years because of this pain. He's been disabled. So, all right. Now, how often do patients with back pain also have neck pain? The answer is 2/3. 66% of patients with chronic back pain will also have neck pain. It's very common to have both. Okay? Very common to have both. Any questions?
Yes, we have a few more questions. Next one's coming from Faisal on Facebook.
It's been a while since we heard from Faisal.
Yes, we have.
Welcome back, Faisal.
Saying, hi, Dr. Duke. What's going on?
Hi, not much. How are you, Faisal?
Saying,
You keep coming, but you don't come.
I know.
You come to the surgery live streams, but you haven't come here to get your body fixed, Faisal.
Does ask interesting questions. First question they ask is, I know this is out of scope. If you have a benign 8th left rib tumor, Is that still part of the spine? And how would you treat it if it's causing pain and compressing organs? Thanks, by the way. I love watching your laser surgery. You're very skilled.
You're welcome. Well, a tumor of the rib is not part of the spine. And, whether or not I can take that tumor out depends on exactly where it is and has it invaded your pleural cavity. The pleural cavity is the part of your body that houses your lungs. If the tumor has invaded the pleural cavity, you must have a cardiothoracic surgeon remove it. They're the only ones that can take it out safely. Anybody else, you would be putting your life at risk for having a serious complication. So, yeah, you need a cardiac anesthesiologist. So if the tumor is benign, as you say, it's unlikely that it's invading your pleural cavity. It's unlikely to be invading the pleural cavity. It's more likely that it's just growing on the rib and it's contained by the periosteum, which means it should be pretty easy to remove. If I had to remove a benign tumor of the rib that did not invade the pleural cavity, I would just go in and cut that part of the rib out, just to make sure we got the whole tumor and it never came back. If you start messing with the tumor itself, you can potentially spread tumor cells, but also you run the risk of leaving behind some of that tumor and it coming back and having to do another surgery again in the future, which you don't really want done. Here's all pieces of herniation. You guys see all that coming out of the foramen? Hold that there.
Yes, sir.
Okay. If it twists, then I can't get the scope in and out, all right? Unless I reorient the scope. Okay, good. So there's your answer. Most likely, if it's benign like you say it is, then it should just cut out part of that rib. No big deal. You'll never miss it. It should be a safe and quick procedure. On the other hand, if it's invading your pleural cavity, then you need a cardiothoracic surgeon to do your surgery. Any other questions?
Yes, we have a few more questions. Next one coming from Jason once more on YouTube.
Jason and the Argonauts. Yes, Jason.
Asking, I am sure I have bad disc in the neck and back, but I have no idea how it happened. I went into back spasms while lifting. Is that a sign that that's when discs get damaged or become worse?
Yeah. So the back spasm is typically a sign when you were lifting when the disc became more herniated. But the original injury to your disc did not occur in the gym or lifting something. The original injury must have occurred when you were younger. And some people say they never had an accident, and that's fine. But for a lot of people, that injury occurs during birth, when they're coming out of the birthing canal. If you had a delivery, like a vaginal or a C-section delivery that was traumatic, for example, where maybe you were desatting and the OBGYN had to get you out quick, they may have grabbed your neck and your spine and pulled really hard. And, who's going to win? A baby, infant, whatever, newborn spine versus the strong hands of an OBGYN. I've seen those deliveries as a medical student. I know, hold it right here. I know how forceful they can be and how they can actually harm the baby. I remember watching my first delivery where the OB-GYN grabbed the baby's head and twisted it in flexion and twisted the whole spine and the body out. And I thought to myself, my God, that is so forceful. How is it that baby is not harmed? So I truly believe a lot of spinal injuries occur when people are being born. I have no evidence of that, but it wouldn't be too hard to do MRIs these days and figure it out. It's not something I can do. I don't have access to newborn infants. Wow, look at all these herniations. There's another one. That's a big one. Yeah, let's stay on top of the irrigation. Great questions so far. Any others?
Yes, we got a lot more. This next one from Faisal once more on Facebook saying, Doctor, is it true that the discs in the C-spine don't move much at all and most motion is for C1 and C2 and the muscles?
Yeah, so great question. You're right. 50% of movement in the neck happens at occiput C1 and C1, C2. Occiput C1 is your skull attached to your C1, and C1, C2 is your joint between your number C1 and C2 bone. 50% of the movement of your neck, flexion and rotation, occur at occiput C1 and C1, C2. The other 50% of the movement occurs below C2. We call that subaxial spine, and that is your discs, basically. So that is correct. 50% of movement of your neck is C1, C2, and above C1, which is occiput C1, and 50% of the movement of your neck is below C2. Huh?
This next one is a comment coming from Lanu on YouTube.
Sure.
Saying, I think most people didn't come to you because of location. They need to fly to Florida and not be afraid.
Oh, I agree, Lanu. People should be afraid of having invasive spine surgery. I try telling them that. That's one of my main points. It's not about convenience. This is your spine. It should be about safety. People should be more concerned about safety than they are about convenience, or cost, for that matter.
They have a great staff, a great focus.
Yeah, I don't think people understand. They trust their spine surgeons too much, but their spine surgeons are not offering them the best surgery. They're offering them the best surgery for the spine surgeon, not the best surgery for the patient. And unfortunately, people don't get that. You know? I mean, look, I think when people are willing to travel and go to the best, they're going to get the best results. But people don't seem to understand that. They think all spine surgeons are equal. They don't understand there's a huge difference. Not just spine surgeons, but also any kind of doctor. My father was the best OBGYN in his town, and there were many other OBGYNs that patients could choose from, but they chose him because he had the best results for women and men, and he did deliveries, he did tumors, pelvic tumors. He did all kinds of treatments. He did infertility back in the 80s when it was just starting. And he was the best at doing it. So people came to him from all over California. Back then that was a big deal. Like people would travel from an hour, 2 hours away to come see him. And most people just go stay where they are, where their OBGYN is. Look at that herniation right there. It's so big I can't even get it out. So my dad was so good at being a doctor that patients would come, 2-3 hours away for him. And that was a big deal. Look at this piece of herniation. It's just one of many pieces. Look, see them all here?
Yes, we do.
These are all floated out of the tube once I release them with the laser. But this one piece right here is a good size. It's about 4 millimeters. So it's just an example of how small these pieces are. And it's not the herniation, one herniation, that causes symptoms. It's when you add them all up together. That's when, I think I'm done here at 6-7. That's when they cause problems, okay? So it's the cumulative effect of many pieces of herniation that cause the symptoms, okay? They cause the inflammation. I need to get access to my pedal. Where is my pedal? You're covering it up with towels. I can't find it now. Okay, don't do that. Yeah, that's laser technician rule number 1, don't hide the pedal, because the surgeon can't use the laser. Okay, just about finished. I've got about 30 seconds left at C6-7, and I'm just cleaning up the rest of this foramen. There's still a little bit of herniation here, and then we're going to leave 6-7 and go to 5-6 and do 5-6. Okay? So my point is, smart people understand that the choice of which surgeon and which type of surgery matters in their life. It's going to have a profound impact on their outcome, how well they do, whether they have a complication and they have to live with that complication. And unfortunately, spine surgeons are failing their patients today. And it's not just spine surgeons, because I go to the doctor too. It's every single kind of doctor out there. They're not trained equally well, and they're not equally motivated to provide their patients the very best medical care possible. Okay? And what I mean by that is, even an eye surgeon, there are some that do cataract surgery and they do a horrible job, and there are some that do like a perfect job every single time. And the surgeon you want is the one who's going to do the perfect job every single time. Okay? And that does exist, and you have to find them. We are the Messi of spine surgery. If you know soccer, you know who Messi is. You know, you don't have to look far to understand the concept that there are better out there, right? Just look at Messi, the best in the world, or used to be. Okay, if you want to hire a soccer player for your soccer team, that's the guy right there. And nothing against female soccer players. If you're talking about female soccer, then it's going to be the top female soccer player. The point is, some people in life just try harder to be better, and it makes a difference in the outcomes, in their performance. It makes a difference with spine surgery. You don't want an average, mediocre spine surgeon who has complications, because then you're going to have that complication and have to live with it the rest of your life. All right, let's show the audience. I know we have more questions, but let's show the audience how does a herniated disc in the neck cause neck pain, and how we fix it.
Of course.
We're going to move from C6-7 up to C5-6. Spine, shuffle, slide, shuffle, slide. We call this the Duke spine slide. Moving from one disc to another. Okay?
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963. Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4mm skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debreeds the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
There. We'll come back. Pressure here. Did you, let me know when you're ready. Shot. Lateral. Let me have it. Did you show both videos or just one?
Both. Correct.
All right.
Both videos.
All right, this is the hardest part of this entire surgery. So I'm going to focus for a moment on what I'm doing. And shot. Give me an AP. Move it.
Let me know when you're done.
Go. Shot. Perfect. Let me have it. Lateral. Hammer. All right. Good. We're right there. We're right in the center. We're right over the disc. I'm going to sink the tip of the dilator into the disc. Now, we just went from one disc to the next because we have 3 discs to fix, right? And this movement, we call it the Duke spine slide or shuffle. And basically, we're shuffling from one disc to the next without coming out. We're sliding along the anterior longitudinal ligament, anterior surface, and basically moving up to the next disc. What this does is this allows us to go from one disc to the next and treat multiple herniated discs in one surgery with one incision. Shot. That's what I'm doing. One incision, treating multiple discs. Why is that important, Sean? It's important because it allows us to A, do one surgery rather than 3, B, make one incision rather than 3, and C, avoid the possibility of injuring the carotid artery. Show us the tear in the back of the disc. The carotid artery, the jugular vein, there's the tear. Show us the herniation. You guys see that little curve right there? That's
Yes, we
dye
do.
wrapping around the back of the herniation that's pressing on the nerve and spinal cord. Give me an AP view. I'm going to show you an AP view of the herniation in just a moment. All right? Let me know when you're ready. Shot. All right. Now, take a look at that AP view. You guys see that?
Yes,
it
we do.
looks like a line, a black line at the back of the disc. So show us, there you go. There's one tear on the right. Remember, his right side was worse. And look at the size of that tear on the right, bigger and worse than the one on the left. There is a tear on the left as well. And it leads right out to the foramen where the nerve root is. This is important. This explains how annular tear and herniation can affect the nerve roots and cause not just neck pain, headaches, and arm symptoms because the dye is leaking out through the tear around the nerve root going down your arm. And it's a chemical irritation. It's what I've been saying for years, a chemical irritation. It's not a physical compression. It's a chemical irritation of the nerve root. That's what causes arm pain. And these other neurosurgeons, I've been trying to teach them this for years. They don't listen. They all look for big herniation equals fix it with surgery. But it's not a big herniation that causes the worst symptoms. It's the small ones. It's really the inflammation in the tear that causes the symptoms. All right, you can see the tip of the dilator is right inside the annular tear at C5-6 in the back of the disc. Show us that. Yes, here's the tip of the dilator sitting in the tear. So I'm going to advance now the tube. This is a 4-millimeter tube. It's going to go all the way to the back of this disc. Shot. People ask me, Dr. Duke, aren't you doing damage to the disc? No, we're not. This is a jelly we're going through. Imagine taking a chopstick and sticking it in a thing of Jell-O. And then you see the chopstick in the Jell-O, and then you take it out, and the Jell-O is back to normal, right? Shot? So, is that it?
Yes, sir.
I need a little inline.
Got it.
I'll tell you when. Pressure here. Let me know when you're ready. Shot. All right, we're going to do a little inline to get this, because there's so much inflammation in this disc that it's literally bone collapsed down, scarred down to bone, and it's keeping me from advancing my tube to the back of this disc. So it's like making it difficult. But we're going to get there. Give me 1 second. Stay in line. Stay in line. Shot. I don't want to go back too far. Remember what's back there, nerves. We don't want to affect the nerves. Sean? All right, almost done, Sean. Yeah, this is a worse degenerated disc than the last one. So 5-6 is more degenerated than 6-7. Sean, you guys ready? Here we go. Sean, almost there. Done. All right. We have just transitioned our tube and equipment from number 6-7 to number 5-6. We're going to move it from here up to number 4-5, hopefully. Otherwise, if not, I have to place another needle, which is fine. Whatever is safest for the patient. You guys see the incision?
Yes, we do.
Okay, we're holding a little pressure. He's got a little venous ooze, but it's not a big deal. He's probably lost 1 cc of blood, 1 ml. If we did an ACDF on this patient, wait, keep the light on. If we did a typical, what every other spine surgeon would recommend, which is fusion or artificial disc, I need light here. Where is the light? Turn the light back on. That's why I said keep the light on. That would be the operating room light. Whatever we had on earlier. What are you doing with his head? Please don't. If we had to do an ACDF, the incision would be like this. Okay, 3-level ACDF. It's about a 5-inch incision. Now the problem isn't the incision in the skin. Who cares? You got a small incision, big incision. It's going to create a scar, small scar, big scar. Nobody cares. It's what happens underneath the skin that matters, folks. This is what separates this surgery you're watching from an invasive ACDF or artificial disc surgery, is all the damage to the muscle and bone and ligaments under the skin. Those surgeons cause massive damage. That's why people can't swallow after ACDF surgery, because there's so much trauma to their soft tissues, okay? And they have hoarseness, and they have all kinds of scar tissue after ACDF. With our procedure, there is no scar tissue because we're not cutting muscle, we're spreading its fibers. When you spread muscle fibers, it doesn't get damaged. All right, let's go down and fix this disc and move on to the next. Questions?
Yes, these next 2 questions are coming from, love the name, Sandy Tomato on YouTube.
Sandy Tomato. Are you kidding me? Sandy Tomato.
Sandy Tomato.
I love the name. It just creates that image of a Sandy Tomato.
Sandy Tomato, correct. Yeah.
Right? I mean, I like tomatoes with garlic
Yeah.
and cheese,
Yeah.
but I don't like tomatoes with sand on them. But maybe Sandy Tomato grows tomatoes in sandy soil.
Exactly.
Maybe that's what Sandy Tomato is all about. It's the media in which the tomato is grown. All right, Sandy Tomato.
First question
We'll
they
take your
asked.
question.
First question being, how to stop precisely in front of the cervical intervertebral disc and spine to prevent collision with the spine?
Well, great question. I don't know, a lot of people really, most people should know by now that I'm a neurosurgeon. Neurosurgeons are the most highly trained of all surgeons in the world. We go through 7 years of training after medical school in the United States, and they select the very best students for neurosurgery, the top of the class in medical school typically. Can't say that always though. But that said, we are highly skilled surgeons. We're used to, performing surgeries that are very delicate right next to the spinal cord, the spine, the nerves. And that's what we do as neurosurgeons, right? We operate on the brain, the spine, the nerves, the spinal cord. So we've got to be good at what we do. We have to be careful. That said, there's huge variation in the quality of neurosurgeons around the world. There are very good neurosurgeons in every country, and there are very bad neurosurgeons in every country. And unfortunately, right now in the United States of America, which is where we are, a lot of neurosurgeons don't do endoscopic surgery like this. They're doing invasive surgery that is very dangerous for the patient. It has high complication rate, The complication rate of our surgery here, the Duke laser disc repair, is 0. We've had 0 surgical complications in 20 years. I've never had a surgical complication. So, will I always have 0? Probably not. I mean, I feel like the fact that we've had 0 complications is a reflection of my careful surgical skills, but also being lucky to a degree, you know, not having a complication. But I think it's also a testament to the fact that this surgery you're watching is so safe that a surgeon can do 2,650 of these surgeries and not have a surgical complication. Oh, look at that herniation right there. Did you guys, oh, look at that. It just came out.
We see it?
It was hitting on the nerve root. It's a big scarred up piece of herniation. That's what they're like. They're really thick and hard. If you were to touch this and squeeze it between your fingers, it would feel like a piece of plastic, like a plastic bead. That's how hard it is. Look at that. See the scar tissue, the calcium deposit, the inflammatory tissue, the pink right there, the white of the herniation.
Yes, we do.
I'm going to go grab it out, see if I can get it out by grabbing it, okay? This is why we need a grabber. The grabber helps me grab out big pieces of herniation, but the grabber cannot release the pieces of herniation from the annular tear when they're scarred down to the annular tear. There it is. You guys see it? It's a little hard to see with the white background, but there it is right there. That's about a, 3 to 4 millimeter. It looks like a little asteroid. Point is, a herniated disc is not one piece of herniation, it's about 30 pieces of herniation. So when I'm in here, I got to release 30 pieces. That's really what the main point is here. And they're all small fragments, but they add up to be one big piece of herniation. If you add it all up, okay? It's a giant piece of herniation. There's another one. I'll try to break this up so I can get it out. Hold the tube. The tube. Luis. The tube. I don't want it coming out. Yeah. There's another piece. So you can see this technique I'm using. It's not just about grabbing pieces of herniation. It's about using the laser to free them up, which is 100% necessary using the laser. People laugh and say, oh, he's using the laser. He doesn't need a laser. It's just a gimmick. No, it's not a gimmick. It's absolutely necessary. Now, there's lots of gimmicks in medicine. This is not one of them. This is the real deal. This is the real deal. So why do a lot of spine surgeons not do the surgery? In the United States, the main reason is they're not trained to do it. And the reason they're not trained to do it is because the companies that sell the metal, the screws and rods, the plates, the cages, the artificial discs, those companies don't want them doing this surgery. Do you guys know why? The answer is simple. Because we're not putting any metal in the patient's spine. Those companies only make money when the surgeon puts metal in the spine, whether it's an artificial disc or it's a plastic cage or it's a metal plate and screws. Those companies make billions of profit when the surgeons are putting metal in people's spines. That's why the surgeons are recommending metal for your spine when you have an ACDF. There's another piece of herniation. You see that? Another big one.
Yes, we do.
Thanks, Luis. Good job. All right. So you are all being scammed around the world by your spine surgeons who are recommending invasive surgery with metal implants because they're making a ton of money doing those surgeries. Plus, the companies that manufacture those products are pushing the surgeons to do those surgeries on patients. Plus, the universities where surgeons are trained around the world to do spine surgery, those university chairmen, those surgeons that are teaching the surgeons, the next generation, they are being paid off by the companies that manufacture those implants. And you, the patient, are unfortunately being recommended for a treatment you don't need that's harmful to you when you could be having this treatment. But the surgeons don't want to recommend this because they're in cahoots with the implant companies. All right, there is a tear right there in the back of the disc. You guys see that?
Yes,
that
we do.
is a tear not in the annulus, that is beyond the annulus. So beyond the annulus is the Anybody know? Posterior longitudinal ligament. Okay, it's a ligament that runs along the back of the disc, right in front of the spinal cord. It's called the PLL. And there's a tear in the PLL right there. Now, is the laser on? The reason it's important, folks, is because, well, let me turn around and get that little guy. The reason it's important is there may be a piece of herniation beyond it pushing on the spinal cord, and I need to remove it. Otherwise, I haven't done my job completely. So we're going to go take a look in there in just a moment. Right now, I'm in the foramen, and I'm going to clean up this foramen, then we'll get back to that PLL tear. This is the foramen. It's where the nerve root is. The nerve root comes off the spinal cord here and actually travels down into the down to the arm in this area. All right, looking good. I switched one piece of blocking herniation for another. How funny. Okay, when I say blocking, I mean blocking my view. I've got about 2-3 minutes left on this disc. Look at all that herniation in the foramen, guys. This is the left foramen. Yeah, left foramen. A lot in the left foramen at C5-6. Look at all that herniation right there. Bad stuff. Getting rid of it with the laser. How precise, how beautiful, no bleeding. There's no hospitalization for this surgery, folks. You come here and get it done. It's outpatient in our center. We have the most advanced spine center in the world for degenerative spine problems like herniated discs. We have the best equipment available in the world to treat disc problems. We have the best endoscope, the best laser, the best fluoroscope, the best operating table, the best anesthesiologist and staff, the best of everything for our patients. We want our patients to get the best. The best, you put the best ingredients, you get the best results. All right, any other questions?
Yes, we have a lot of questions. Next one from Sandy Tomato once more on YouTube, asking, is there a possibility of bleeding when the probe passes through the trachea? Does it need to be sutured?
That's funny, Sandy Tomato. So first of all, the probe never passes through the trachea. The trachea is the windpipe. If I put the probe through the trachea, the anesthesiologist would probably come over here and punch me. You never want to go through the trachea. You'll kill the patient. So we go next to the trachea. All right, here we go. Digging down. There goes the fibers. I'm opening up the PLL, looking. What you guys are seeing down there is the actual spinal cord itself. That's what that faint blue smooth thing is. I don't see any more herniations down here. But that right there is his spinal cord. Right there. I'm touching the dura of the spinal cord. And I don't see any more herniation. So I'm going to check one more time. Yeah, so we don't go through the trachea. We don't go through the carotid. We would kill the patient if we did that. We're not going to do that to the patient. Let me come back this way one more time. We go next to it. If you notice in the beginning, I use my fingers to push things over. I'm pushing over the trachea, the carotid artery, the carotid sheath, the vagus nerve, the jugular vein. We're pushing over all those important structures so I don't damage them. Okay, pushing them out of the way. This is not a weekend course. Let me go take a weekend course and learn how to do this. This is a 1 year or 2 year fellowship that the doctor has to do with me to learn how to do this kind of surgery. Good. All right, let's keep going on questions. We're done with disc number 2. We're going to go on to disc number 3.
Lights on, please.
Meanwhile, take a look over here. No bleeding, tiny incision. We're not putting any metal. You don't need metal. The patient has a disc already. We're not taking his disc out. This is not a discectomy. This is an annular debridement. Annular debridement and what we call a herniectomy. Hernia is the herniated disc. Ectomy is to remove. Herniectomy, remove the herniated disc. So I'm doing a herniated disc removal plus annular debridement with the laser, and that's what this surgery is all about, the Duke laser disc repair. Did you show the video of the DLDR?
Yes, we did.
Let's show it one more time, and then we'll get back to questions.
Copy that.
Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4 mm skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debrides the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Welcome back. So you can see from the video what I'm talking about. We go in endoscopically to the back of the disc where the posterior tear is and herniation. That's where all the neck pain comes from. That's where all the headaches come from. That's where all the arm symptoms come from. You saw that tear on the discogram earlier. Well, we went in and cleaned that tear out, got rid of the herniation stuck in it, and now we fixed that disc. His pain will be gone tomorrow when he comes back. You'll find out. We're going to fix the last disc right now. This is number 4-5. I'm going to try to make my way up, sliding along the ALL, doing the Duke Spine slide, or Duke Spine shuffle. What was the name of that slide? The electric slide. That's where we named the Duke Spine slide from. The electric slide. And we used to play that song years ago while we did the slide, just to motivate everybody in the operating room, you know. You guys have seen those scenes shot of the prisons in Thailand where the inmates are all dancing. We used to have something like that here, minus the inmates. AP, but everybody would be doing the Duke Spine slide in the operating room to the music of the electric slide. All right, so we're too far to the right. I'm going to move my dilator back to the left. I slid out to the right too much. So there we go, back to the left. And we'll get another x-ray and see where we are. Shot. Perfect. I'm dead center. You guys see that? Dead center. That's where we want to be. By the way, those black lines are the trachea, endotracheal tube. You see we're not going through the tube. Show us the tube. Okay, there's the line through the tube, but show us the other side of the tube. Nope. Left. Left. Left, left. Stop. That's the other. You can see a shadow of the tube go up. Okay, there you go. That's the tube. So we're not anywhere near the endotracheal tube. To answer Sandy Tomato's comment. We're almost there. I got to slide a little bit more. I'm going to see if I can do that safely. Shot. All right. Shot. I'm off to the side. I need to figure out which side I'm off to. AP. Any questions?
Yes, we have a lot of questions.
Shot?
Next one
I
from
think I'm
Jason.
off to the right. Yep.
Once more on YouTube, asking how many Smurfs get sacrificed for that magical blue dye? How does it know what to stick to?
That's awesome. I love it, Jason. Love it. You know, it's sad because a lot of people don't even know who the Smurfs are. And what we do is we did a midnight raid with SEAL Team 6 to Papa Smurf's cabinet of curiosities, and we found the blue dye in there, and we've been using it ever since for about 19 years. The blue dye is a dye called we call it the Duke Spine blue dye, but it's indigo carmine, and it comes from India originally. The dye does. It's the most beautiful blue in the world. It's 430 nanometers blue, 430, 440, somewhere around there. And it's unfortunately very rare and hard to get. But we have our sources. Like I said, Papa Smurf has been generous, AP. And we've been using it for 20 years. What it does is it binds to, serendipitous, binds to degenerated nucleus pulposus. Degenerated nucleus pulposus, basically the herniation. It binds to the herniation, shows us the herniation, so it's easy to see, so we can target it and take it out. Great question. AP? Oh, sorry. Lateral. I may want to get another AP shot. Let's get another AP. So you see me going back and forth, lateral x-ray, AP x-ray. I want to make sure I'm staying inside the disc. Perfect, perfect, perfect. Because if you are to the side, you can kill the patient. We're not going to kill anybody. We don't want to. We like our patients a lot. We don't want to hurt them. But this is the kind of surgery where they can be hurt if you don't know what you're doing. Shot. So, if you're going to have an endoscopic transdiscal cervical procedure, you want the best, you come to Duke Spine. Shot. All right, you can count, Jordan. Count for the audience. C2, 3, 4, 5. So you know where we are. I'm going to do the discogram one more time. Shot. Shot. Is that it?
Yes, sir.
All right, hold on. I got to go in a little bit further. No, I got to go mallet. I want to go a little bit further in. Shot. Yep, perfect. Now, pipe cleaner. Sometimes we get a little nuclear material inside the dilator. Shot. Shot. So I watched one of my favorite movies last night. Since we're doing something, I can't really take questions. It's a movie by Mel Gibson from back in the 90s. Okay? And I encourage you, if you like Mel Gibson, to watch this movie. Shot. It's called Payback. I've watched it probably 5 times. It never gets boring. Payback with Mel Gibson. He takes on the mob in New York. It's an amazing movie. It's very hard to find. I got it on Apple Movies. It took me years to find it because Apple didn't have it. Apple actually didn't have it until recently, and I was able to get it and watch it. All right. Can you give me a little inline, Berndes? Let's take some more questions. Payback, great movie. Very entertaining.
I'll put that on the list.
It's actually got Lucy Liu. For those of you who don't know Lucy Liu, she's one of my favorite actresses.
She's great.
Fantastic actress. Sean?
Next question coming from Hassan on YouTube,
Yep.
saying, "Hi, doctor.
Hi.
I've seen your posts. I would like to know more about lumbar discectomy and the procedure you are currently performing. What is the difference between them? Thank you."
So, first of all, we're operating on the cervical spine, not the lumbar. So we're on the opposite side of the spine. But the procedure is called the Duke laser disc repair. And Henry will put a link to a video where you can watch our Duke laser disc repair video to understand what we do. Inline, let me have it. For some reason. But basically, remember, this is not the lumbar Duke laser disc repair. You guys giving me inline? 2, 3, 4, 5. This is the cervical Duke laser disc repair. So if you watch the lumbar, we're operating on the lumbar spine. We're going from the back of the body, patient's back, back side, and we go through the foramen. We don't go through the disc, we go through the foramen to get to the tear and herniation. So the most important distinction between discectomy and Duke laser disc repair in the lower back is, number one, we're not cutting any bone out like discectomy does to get to the disc. Discectomy cuts out the facet joint, which weakens your spine and makes it fall apart. Discectomy cuts out the lamina, which is normal, and you don't want to take it out. They take it out. Discectomy cuts out the ligamentum flavum, which is the ligament that holds the bones together in the back of the spine. Discectomy cuts through the interspinous ligament and even a lot of times through the supraspinous ligament. So basically weakening and destabilizing your spine. Duke laser disc repair does not. We don't cut any ligaments at all. And discectomy cuts the muscle in the back of your spine, killing the muscle, causing it to turn into scar tissue. Duke laser disc repair does not cut any muscle. There's a few differences. Duke laser disc repair does not have bleeding. Discectomy does. Duke laser disc repair does not create instability. Discectomy does. Duke laser disc repair does not require postoperative narcotics. We don't give patients painkillers afterwards because they don't need the painkiller because they don't have pain. Discectomy, you have to take painkillers. Discectomy does not get rid of back pain. Duke laser disc repair does. Discectomy is only done to treat a pinched nerve, which causes leg symptoms, not back pain. Pinched nerves never cause back pain. Pinched nerves cause leg pain or weakness, numbness, and tingling in the leg. So, Duke laser disc repair cures back pain from the disc. Discectomy never cures back pain. If you ask your surgeon, will your discectomy cure my back pain? They're going to tell you no, it will not. You have to go to pain management for your back pain. We don't send patients to pain management because they don't have pain. All right. Great question. I think that summarizes a few of the differences.
And I also sent them the link of the animation of the how to cure discogenic back pain.
5 minutes. Yep.
So then coming up, next question is from Faisal, once more on Facebook.
There's not a whole lot here. A lot of scar tissue, but not much herniation. Yep, Faisal, go ahead.
Asking, I will come see you soon to get my neck fixed. I will aim for early next year. The rib tumor is benign, and I have one at that level. It's contained in the bone, and it's slowly growing, but it is horrible. I saw the oncologist MDT meeting report that they feel maybe fibrous dysplasia or
osteoid osteoma or osteoma.
Something like that, yeah. And I had spine surgery to review it. Oh, I had a spine surgeon to review it who says the treatment is pain management. Maybe as he is not a cardiologist, thoracic spine surgeon, that's why he's advising that?
Well, look, the reality is if the tumor is confined to the bone, and that means it's not spreading into your thoracic cavity, then you got nothing to worry about. Okay? You don't need a thoracic surgeon. Only if it's spread into your thoracic cavity.
Maybe cause of pain though.
We're done. That was an easy, quicker one. It wasn't as herniated as the other two, so I think we're done. Great job, my team. I'm so pleased. You all did phenomenal. And our next surgery will be a 2-level lumbar Duke laser disc repair. So it's a patient who has herniated discs in the lower back that need to be treated with our laser procedure to get rid of back pain and leg symptoms. All right, keep going on the questions. I'll answer them while I'm finishing up with this patient's surgery.
Coming from Lanu, once more on YouTube, asking, can herniated pieces considered life forms? They don't seem to breathe oxygen.
Lanu, that's awesome. Yeah, they're not life forms. They're inanimate objects. Herniations are nucleus pulposus, which is glycosaminoglycans, 70% water, 30% glycosaminoglycans and proteoglycans, which are basically just sugar protein molecules designed to hold water and create a gel, like jelly. Next question.
Coming from Jason, once more on YouTube, asking, how do you have the patient oriented and where is your entry point? Is it always the same?
So, yeah, great question, Jason. Our patient is covered in drapes and the neck is exposed. The entry point is either right side of the neck or left side of the neck. This is the chin right here. His eyes are here. Do we have a marker? Let me have the marker. I'll show you. I'll show you his face. All right. Here's the eyes. His ojos. I was never an artist, so don't fault me. Here's the nose. Here's the forehead, and the hair is up here. The mouth is here. And he's got a tube coming out of his mouth, heading over to the machine. That's the orientation. Next question.
Next question from George on YouTube.
There's the incision. We've lost maybe 1.5 milliliters of blood. It's nothing. This patient's going to go home in an hour from now, fully recovered. Yes, George?
Asking, why do some patients experience significant symptom relief after an endoscopic posterior interlaminar decompression, even when the intervertebral disc itself is not directly addressed?
That's a great question. I don't know that they do, but I would attribute it to the painkillers that they give the patients after surgery rather than truly relieving pain.
Last two questions. Next one from Faisal once more on Facebook asking, Doctor, why don't you do a clinical trial and publish papers of the surgeon and its effectiveness? Maybe it will convince insurances to approve your procedures?
That's a great question. So we have published, we have done clinical trials, we have published. Our papers are in PubMed. They're out there. We have over 10 peer-reviewed publications for this surgery. We have long-term outcome, lumbar, Duke laser disc repair, 6-year average follow-up, 92% elimination of back pain at 6 years. We have cervical Duke laser disc repair, safe and effective. It's in PubMed. Just type in Duke laser disc repair in PubMed. You'll find our publications. The insurance companies do not want this surgery available because they know it works. And what's going to happen is if they approve it and start paying for it, which we do have some pay, by the way, we have over 120 payments from insurance companies. If all of them accept it and pay for it, everyone's going to come here and get surgery. Because right now, only about 1 out of 20 patients will have surgery because 19 out of 20 know that surgery doesn't work and it's dangerous. Therefore, they won't get the surgery done. But that saves the insurance company money because people are refusing to get invasive surgery done. Once you make a surgery that has no downtime, not invasive, no bleeding, no hospital, no recovery, recovery is 1 day, you're back to work the next day. Once you create that surgery, everybody's going to want it. And instead of 1 in 20 patients having surgery, 20 out of 20 patients will have surgery. The insurance company will have to spend more money on surgery of the spine, which is, by the way, the #1 problem in the United States and the world. 1 billion people with chronic back and neck pain. They know 1 billion people are going to want to come have this expensive spine surgery. They don't want to cover it. We've done everything possible to prove it. We have videos, we have testimonials, we have peer-reviewed publications. They are not going to cover the surgery willingly. We're going to force them to cover it with a lawsuit. That's just the reality of life. That's like asking for somebody who's committed 20 separate murders to rehabilitate themselves and become a cruise tour director. I mean, it's just wishful thinking. That's asking Satan to become God. I mean, you're asking for the impossible. You're asking Hamas to love Jews. You're asking Ukrainians to embrace and put out food for the Russian soldiers. I mean, you're asking for the impossible. And that's how ridiculous it is. It's even worse than that. It's all of those combined.
And then lastly from Hassan, once more on YouTube, asking, what do you upload after you finish something in syringe? What is that?
Yeah, great question. What that is it's antibiotic first. So we're putting in something called betadine, which is iodine-based antibiotic, so that we don't get any infection with the patient. And then we irrigate it out, and then we put a little anti-inflammatory so we don't get too much inflammation from the surgery. All right, thanks for joining us. We'll be back shortly in about 45 minutes for the next surgery. Please join us.